All right, let's talk about running sutures. And you've got that same two of Vicryl. So instead of the interrupted where we've got this space in between that's not being directly compressed by the suture, a running is good for a little bit more efficient way to close long openings, to get relatively even tensioning across, and to some degree a bit more hemostasis because the tissue is being a bit more compressed. But in a minute, we're going to take a look at a running interlocking suture that gets even better hemostasis. So in general, we usually start up beyond the apex of the incised or lacerated tissue because any divided tissue could be a source of bleeding. So we want to come up just beyond the apex. See our needle tip here in the middle. We'll come out in the middle, regrasp, go back in, and again pop out just up behind that apex. So what we've done here is we come to tie this, and we're going to do an instrument tie just because we are running a little bit short on this suture. But what we've done is we've made it so that as we tie this and get tissue compression, we have the beginning of tissue compression up beyond where the tissue is actually divided. So every bit of divided tissue, possible areas of bleeding, cut or exposed blood vessels will be kind of within the line of our suture. So let's talk about instrument tie real quick. Wrap it around, it's the same thing. It's just getting a loop of tissue and then pulling a free end through it. So wrap your loop around the tip of the needle driver and pull through, wrap the loop around and pull through, wrap, and through. So 4 throws there for Vicryl. All right, so instead of cutting both sutures, which we would do if we were doing just an interrupted, we just cut the short suture, the part with the needle attached, we've obviously left attached. And so now we're just going to come down and do side to side. And again, here we're doing in kind of one pass, reloading the needle at the tissue, pulling that through. Here we'll kind of come out in the middle, say we've got a bigger gap here or real deep. Now we're also trying to get all the way down. You can see how far deeply the tissue is divided down here. Again, any divided tissue, whether we've incised it or it's torn open because of laceration, you can see where my needle's coming out. So everything from my needle up is going to be contained within the compression area of the suture. But all of this tissue down here is not going to be contained. So there could be ongoing bleeding there. And it might not be as well reapproximated. So you could look at ongoing bleeding, potentially hematoma formation, potentially a bit of a gap there, a little gaposis where it's not going to heal as nicely. This is a little bit of a smaller needle than I would typically use for a deeper wound like this, but let's back this out, take a little bit of a bigger bite there. Now I've gotten down really to the bottom of that defect. And then with this next bite again, I want to get all the way down to the bottom of where that defect is started, and then curve my way up there. And pull that through. And then we just keep doing that. So in here, come out in the middle so I see my needle tip. Can control exactly what depth of tissue that I'm going down through. Curve that out, reload at the tissue, and pull that through. Now, you can see here that the skin edge on the left is really tucked up right against the edge of our incision. The skin edge on the right here is kind of falling off to the side, so we have what looks like a little bit of a gap. So if I wanted to correct that, I could really grab skin edge itself and to make sure that I'm really incorporating that into my bite. So now, as I come across here, hopefully that will get that right skin edge a little bit closer. The other thing that I can do is to actually grab and pull that over so that as I tighten the suture, so you can see the difference between having a little bit of a gap in skin edge here and then how closely that bite brought it over. So again, I'm going to kind of grab skin edge, and I can evert it to see right where my needle tip is coming out. come across here in one bite, drive a little bit more of that needle length through. And then again, as I'm tensioning down the suture, I can kind of grab tissue and place it where I want it and get the closure that I want. So again, we've got a little bit better closure on the skin with those last couple of throws. And we'll do one more here. All right, so now that we're getting towards the end of our incision, what I typically do, because again, we want to have both our first and our final pass of the needle and suture beyond the apex of the cut area. So I don't really feel like I have enough room here to do one more bite through the tissue and then one beyond. So I'm just going to do one more right beyond, just a little through and through like that. And then when I go to tie this, all of that tissue will be contained kind of within our suture, so to speak. And since we're short here, again, I'll do a little instrument tie. We're going to do a little wrap, grab that loop with my very cheap needle driver and pull it through. And again, loop around the tip of the needle driver, grab my free end, pull it through. There you go. And that's just 2 throws, which normally we'd do 4 for Vicryl. And then we'll cut that. So, running continuous suture, talked about the different depths that we get to. We want to make sure that we start and end beyond the apex of the defect, that we want to go full depth of the defect to get all of that divided tissue, areas of disrupted blood vessels, and so sources of potential bleeding contained within the suture so that it's going to be compressed.